Right. So we'll discuss about the physiological basis of cardiac support. So now I'm pretty sure you would have learned about cardiac function and the basic cardiovascular system function and how it affects on each and every organ in a previous lecture. So here, what I'm focusing at is, so based on the knowledge that you have got about the cardiovascular system, we are going to relate the physiological basis of cardiac support, physiological basis of cardiovascular system with the cardiac supports that you will see in your clinical practice and how it is being adapted to support a patient's deteriorating cardiovascular system, right? So let's see, we'll quickly recall the physiology of the heart working as a pump and apply the cellular knowledge in understanding how the ionotropes work. And let's analyze cardiovascular monitoring in relation to physiology that you have already learned, right? So why do we need to support heart, right? So you know the heart is made out of a special muscle, which is the myocytes, and it has this inherent property of contractility, and it has the self-excitability as well. So in the microscope, this is how it appears, the myocytes, and they are attached with the junctions like this. And so the way that the heart works is described by the Frank-Starling mechanism. So to describe that, you know the basic Frank-Starling curve, which nicely explains the inherent property of the myocardium, right? So you know, so in this curve or this graph is very important again for your exam. So the examiners might ask you to scribble this down and describe what it is. So if you, so the Frank-Starling mechanism is very easy to explain with this graph. So if you look at this, the x-axis is the left ventricular end-diastolic pressure or the preload. So you know, during cardiac contractions, the left ventricle fills in the end diastole and it collects a volume of blood which is ready to be sent out with the next contraction. So which is known as the preload. So the pressure develops with this volume of blood within the ventricle. So as the volume fills up, you know the myocardial, the myocytes, the fibers, they get stretched. So as they get stretched and stretched, at a optimal level, the myocardial cells are geared to self-contract. So that is how the systole happens. So there is a pressure that is building up in the left ventricle at the end diastolic, and then with that, with the stretch, it gets inherent contractility and a volume of blood will be ejected from the left ventricle. So in a normal heart, you will see with the rise of the end diastolic pressure, the stroke volume proportionately rises, but after a point, when it is going into too much of stretch, the stroke volume will not further rise. However much you stretch, you will not see a rise in the stroke volume. Instead, after a while, you will see the stroke volume is reducing. So that is the function of a normal heart. So suppose the myocardium is sick and the heart is unable to contract. Let's say the heart has sustained a myocardial infarction. So a segment of myocardium is infarcted. So if that is the case, then the heart is unable to pump out the blood. So what happens is, although your left ventricular end-diastolic pressure is rising with the preload, you will not see a expected cardiac output, or rather a stroke volume per contraction. So then your Starling curve is actually shorter than the original normal heart curve, and instead you will see a reduced function in the left ventricle, right? So you might be asked to draw what is the normal curve of a left ventricular contraction. Can you draw this Frank-Starling curve, or can you overlap a heart failure patient's Frank-Starling curve on that and describe the changes? So if you look at the myocardium, so it has this inherent property of contractility. And so when we talk about the heart and how are we going to support the heart has three main entities. So the first entity is the contractility, which is governed by the myocardium. And then we have the preload. So preload is the venous return that is coming into the right ventricle, right atrium, and then to the right ventricle. And then it goes to the left side of the heart. And the ultimate volume that is available within the ventricles is the preload. So with the preload, you decide on the filling pressures. And so that is how you develop the Starling's law of contractility. And then you have the afterload. So afterload is the arterial pressure or the resistance that is opposing the cardiac output. So when the systemic vascular resistance is too much, the heart fails to pump the relevant amount of blood. So which is known as the stroke volume. So per contraction, the amount of volume that is sent out from the ventricle is known as the stroke volume. And if you multiply the stroke volume by the heart rate, you get the volume of blood that is sent out from the heart per minute, which is known as the cardiac output. So, so what determines the stroke volume? So that is the volume of blood that is coming into the heart, and also the contractility of the myocardial cells. So, and not only that, you need some forces or the driving forces for this. So that is the sympathetic nerves, which will stimulate the myocardium for contraction, and also the circulating catecholamines. And artificially, if we give a drug that mimics these catecholamines or the sympathetic response, you can generate a contractility. So if you artificially give a load or a preload, if you give a volume of a bolus, fluid bolus, there you increase your preload and you increase the filling pressures, where you strengthen the Starling's forces. And if your patient's afterload is too much vasoconstricted, and if you reduce the afterload, there you can drop the systemic vascular resistance and you can facilitate the forward flow. So let's see one by one how we can control or change these entities in the heart. So basically, this is a very important slide. Whatever the inotropes we add, whatever the kind of manipulations we do to adjust the cardiac functions is done through these preload, afterload, and contractility adjustments, right? So if you look at the contractility very carefully, again, in a graphical way, you can show it that, as I already told you all, the left ventricle is stretching, the myocardium is stretching with the volume, and as it stretches and stretches, the preload is being developed, right? And then as the further it's stretched at an optimal level, the myocardium can give a optimal cardiac output. But if you stretch it more than that, your cardiac output drops. Similarly, if you do not stretch to the optimal level, again, you will not get an adequate cardiac output. So if you want to get the optimal cardiac output, so your myocardium should be optimally stretched. Right? So that is the learning point here. So let's say you are exercising. Sorry, your patient is exercising and your patient's heart is working really fast. So where the myocardium is getting stimulated by the sympathetic nerves and the heart is getting accelerated. So when the heart is accelerating, you will get increased contractility. So the graph is shifting to another level where you get increased venous return. So the endosteric volume is getting higher and higher. And on top of that, the cardiac contractility is rising. You can appreciate if you look at the normal contractility of the heart, the endosteric volumes are the same. If you look at the increased contractility in an exercise, again, the preload is very much the same, but what we have increased is the contraction of the heart. By that, you increase the stretch as well as the cardiac output. So that is the left ventricular, the ventricular function. Ultimately, we take it as the cardiac output. So let's say you have got a myocardial infarction or a heart failure where the myocardium is unable to contract adequately. So that is a situation where you will get a low contractility, and despite having a preload, the heart is unable to pump out the blood and you will get a low cardiac output. So these are the scenarios that you will see in clinical practice in a heart failure patient. If you check their pulse, the peripheries are very cold and clammy because they don't have good cardiac output. Whereas you might see features of dilated chambers such as raised jugular venous pressures, where there is congested right side of the heart. And you might get pulmonary edema because the left ventricle is unable to pump. Because of that, there is congestion in the lungs and there will be an inspiratory fine crackles. So that is how you clinically correlate it. So let's see with further. So if you adjust your preload, what will happen to the stroke volume? So let's say your left ventricular end-diastolic pressures are being picked up when the venous return is high. So if the venous return is higher, then again your left ventricular end-diastolic pressure is higher. So then your stroke volume also increases. Whereas if your venous return is less, again your left ventricular end-diastolic pressure is less and your stroke volume is less. So if you draw the Frank-Starling curve, you can describe most of the things, and the three main criteria to describe is the preload, afterload, and the contractility. So if you look at the afterload or the resistance to the forward flow in a normal person, based on the preload and the cardiac output, the curve will be like this. And let's say if we have reduced the afterload or we have added some inotropes, so the curve shifts to the left side because there is increased contractility in relation to the given preload. So that is what we could see. So for a given preload, where if you draw a line here, you will see this is the normal, but in a inotrope's given scenario where the afterload is less, you will see a higher cardiac output with the same preload. At the same time, if you see when there is increased resistance to the flow or there's no inotropes, there is negative inotropic effect, then with a given preload, still you will see a low cardiac output and the myocardium is getting quite quickly exhausted and it cannot go beyond a certain level of cardiac output, right? So that is what it shows. So this is another graph that you need to learn and kind of draw. So which shows the relationship of the left ventricular pressure and the aortic waveform. This is the arterial waveform. And then this is the left ventricular pressures. And this is the left atrial pressures or the CVP drawing. And this is the left ventricular end-diastolic volumes and the ECG. So how you correlate with the first and second heart sounds. So I'm pretty sure you all would have studied this and all, because it is important to understand the physiology by, reading a graph is the best way to describe your physiology. So just to recap on systole and diastole, you know the systole is lesser and diastole is longer, and there's a diastolic relaxation also. So if you look at the aortic pressures at the aortic root, so this is how it changes. And so during systole, so the heart is getting, the left ventricle is pumping out blood, and you will see a peak rise in the pressure within the aorta, which is to about 120, which is the black line. And with the closure snap of the aortic valve, you will get the dicrotic notch at the the arterial waveform, and then you get the rest of the diastole. So beyond this is the diastole. So if you can see, so the left ventricle pressures are rising. So this is the venous return coming up. The preload is developing, and here is the contraction. So contraction of the left ventricle, and it develops pressure. Within a very short time, you can see within a matter of a second, it develops the pressure and it exceeds the aortic pressures. So it exceeds the black line. At one point, it crosses the black line where the blood is completely given to the aorta, and then the left ventricular pressure starts to drop. At diastole, it starts to drop, and sorry, it comes to the baseline again, and this is the isovolumetric relaxation time, right? So this is the isovolumetric contraction, isovolumetric relaxation, and this is the complete left ventricular and diastolic filling time, right? And so this is the arterial waveform, which is kind of, if you overlap with the rest, This is how you draw it. So you have the arterial, the pressures developing in the within the atria. So this is the A wave. C wave is the time where the atria is contracting towards the ventricle through the tricuspid and the mitral valves, where you will see a sudden pressure drop, as well as you can see when the black line is coming down, the ventricular pressures are rising because this volume is getting into the ventricles. And so then the first part is a passive filling by the atria to the ventricles, which is about 70%. And then you have the closing snap of the tricuspid and the mitral valves, where there is a transmitted pressure to the atria. So that is why you see a C wave on the CVP tracing. And then there's a X descent, where there's a sudden pressure drop in the atria and slowly it fills up again. And then it comes to the peak. So that is how. And then during ventricular contraction, again, it will get a transmitted pressure to the atria. And slowly the volume is picking up. Right. So similarly, you can appreciate the volumes, how it builds up. So as the atria empties, you can see the left ventricular end diastolic volume comes to the maximum. And during contraction, it comes to the nearly to a very low level. So this is the left ventricular end diastolic volume. So if you compare the left ventricular end systolic volume with the end systolic volume with the left ventricular end diastolic volume, so you get the fraction that is being sent out from the left ventricle. So these are the two parameters we use to analyze the ejection fraction. So you can get the left ventricular end diastolic volume versus left ventricular end systolic volume. So if there is 100% here and there's only 40% left, so it is 60% ejection fraction, right? So if it is opposite, it is 40%. So that is a calculation method we do to assess the ejection fraction. And then you can correlate it with an ECG. So if you try and draw this without looking at a textbook, after understanding what is happening, so most of the cardiovascular related physiology will be in your mind because it is very easy. So atrial systole, ventricular systole, and ventricular atrial depolarization, ventricular depolarization, and ventricular repolarization. So likewise, you can relate it to the electrical activity of the heart. So let's see how our drugs can be used into these places, right? So let's say if you give a fluid bolus, you can increase the left ventricular end diastolic volume, right? Let's say your patient's volume was around 80, but you can pick it up to 120s when you give a bolus. So the contractility of the left ventricle will be increased. You can see if the slope was lower, you can pick it up and rise the blood pressures. That is how you raise the systolic blood pressure, or else you would have seen patients in systolic heart failures where you need to support this part. And there are patients who would have seen in echo reports telling us diastolic dysfunction. So what is this diastolic dysfunction? They say there is grade 1 diastolic dysfunction or grade 2 diastolic dysfunction. That is when the patient's heart is unable to relax during diastole. So it is very important to relax. Otherwise, if it doesn't relax, there is no enough filling into the ventricle. So that is the diastolic dysfunction that is being described in echoes. Right? You would have seen it in patients' reports. So another important thing is to identify is the pressure volume loop, where again the left ventricular function is being very well described, right? So if you start from here, so there is filling of the left ventricle. So where the mitral valve, if you can start from one place actually, and then start describing. So where the mitral valve opens and there is filling of the left ventricle, and then so the endostalic, and then there is isovolumetric relaxation in this part. So the mitral valve opens, so the filling happens, and then once the filling has happened, so from here onwards, the pressure has developed, LV pressures, and the blood being sent out, and then there is the aortic valve which is opening up, and so then blood is being sent out, and there's a sudden drop in the pressure within the left ventricle, and the volume also reduces, and there again the mitral valve closes, and so on. So this graph goes on. So you need to realize and draw kind of similar graphs when you have reduced afterload. What happens to the graph, and what happens when the afterload is increased, and when you have higher stroke volumes, how does the graph looks like? And when the stroke volume is less, how does it look like? So likewise, you should be able to draw this, and this shows the contractility of the heart with this angle. So if the contractility is better, you'll get a better pressure, and so that is the kind of angle of the graph, right? So, and then let me just check the chat box. The previous chart is it this one? The graph, is this the one you want to discuss again? Yes, okay. Right, so this graph shows the systole and the diastole. So this is a graph where you describe about the aorta, left ventricular pressures, atrial pressures, left ventricular volumes, the ECG or the electrical activity of the heart, and the heart sounds. So all being taken into consideration, and we are talking about one cardiac cycle. So that is what is shown here, right? And so you can start from anywhere. So if you look at the ECG, it is the atrial systole or the atrial depolarization, ventricular depolarization, and the ventricular repolarization. So when you get the atrial depolarization, you get the contractility. That is why you see this A wave in the atrial pressure waveform. There is a rise in the pressure. When the pressure rises at one point, it crosses this red line. What is this red line? That is the left ventricle. So the left ventricle pressure is rising because this black color line or the atrial blood volume is passively emptying into the left ventricle. And then there is active component, which is about 30%, and rest of the blood is getting filled here, and that is why you see a sudden rise. And then there is contraction of the ventricle. So when the ventricles contract, you will see a waveform appearing in the again in the venous side or the atria. That is because of the bulging of the tricuspid and the mitral valves to the atria, and you can see the pressure is rising in the left in the ventricle. So if you correlate it with, this is the ventricular depolarization. That is why you see there is an upslope or uprise in the left ventricular pressures. At the same time, you can see the left ventricular end-diastolic volume, which has gone to the peak at the time of atrial contraction, and it has filled the left ventricle fully. And with the depolarization, as the pressures rise in the left ventricle and blood going out to the aorta, this is the aortic graph, the black one, you can see the volume is very rapidly dropping. So this is the left ventricular end systolic volume. So it is reaching nearly 40 milliliters. So it has sent out about 80 cc of total volume, right? So once this volume is being removed, you can see the left ventricular pressures are rising, and it is giving blood to the aorta. That is why we see the aortic pressures are rising like this. At some point, the left atrial, the ventricular pressure is lesser than the aortic pressure. So that is why the aortic pressure is taking up the blood, and it is systolic blood pressure marking as 120. So there, the aorta is taking over the pressure and ventricular pressure is dropping. And you can see next is the snap closure of the aortic valve, and then the blood is being flown out from the aorta, and quickly the left ventricular pressures are dropping because the left ventricle is emptied now, right? So, and then by this time the atria is filling up again, and it is ready for the next filling of the left ventricle. So that is how the cycle goes on. So the idea is for you all to be able to correlate with the aortic pressures, left ventricular pressures, then the atrial pressures, and the left ventricular end diastolic volume. The volume, what happens to the volume, and then the electrical activity, right? And also you can correlate with the heart sounds. Where do you hear the loudest sound? Where do you hear the second heart sound? So likewise, so you can relate it to that. So the closure, snap of the aorta is heard here, and here is the ejection of blood out from the left ventricle. It's the first heart sound. So likewise, you can correlate the heart sounds as well. Right. So moving on. So this is the other important chart that you need to remember, right? So this is the ventricular ejection and then relaxation of the left ventricle. You can see it is isovolumetric because the volume doesn't change. It is the pressure that changes. This axis is the one that is changing, but the volume is the same. And then it starts filling, and then again it starts to contract, right? So likewise, so it goes on like that, and you can see how it is happening, right? So this is one such possible viva question. So somebody can ask, what is cardiac output? Can anyone answer? What is cardiac output?
The amount of blood that is pumped out of the left ventricle in a minute.
In a minute. Yes. Can you tell me the equation for that?
That is equals to stroke volume into heart rate.
Yes. What is stroke volume?
Stroke volume is amount of the blood that is pumped out of the heart in a single beat, madam.
In a single contraction. You can say in a single contraction, the volume of blood that is sent out from the ventricle. Right, very good. So can you draw the Frank-Starling curve and describe? So can you just scribble down and describe me? So whenever you are being asked to draw a graph, so use half of the sheet, the provided one, and draw big diagrams, and you have to start from describing the axis. So this is the x-axis, this is the y-axis, and try to write the volume, the units, whether it is milliliters, whether it is millimeters mercury, right? So that shows that you have understood it. Okay, so can you tell me what are the axis of the graph? So again, go back to the theory. So it is stretch versus the cardiac output, the stretch of the myocardium versus the cardiac output. So what was it showing? The stretch is the left ventricular end diastolic pressure or the volume or the preload, right? So preload becomes the volume and volume becomes the stretch, and that is the pressure that is developed. So the stretch versus what you get out is the cardiac output, right? So it is a pressure measurement that is in the x-axis and a volume measurement in the y-axis, right? And your curve should be very unique, the way you need to draw. So it is a very peculiar graph where you have a rising trend and then it plateaus and slightly it comes down, not really to the bottom, but slightly it starts to turn downwards, right? So you have to be very clear in that. And if somebody asks, okay, draw me a Frank-Starling curve of a patient with heart failure. Okay, then you can draw another graph lower than that, and then you can describe. So heart failure, yes, sometimes this part may be longer than the normal heart. Okay, then somebody might ask, okay, draw me a diagram of a patient who has been started on inotropes. Yeah, so then you can say his graph is quite, I mean, for the given preload, the contractility is more. Then you have more cardiac output within a short time, right? So that likewise, you need to try and describe this, and you should be able to talk about the contractility, preload, and the afterload. Right. So can you tell me how does cardiac output contributes to blood pressure?
Blood pressure is equals to, madam, cardiac output over systemic vascular resistance.
Yes.
When the cardiac output is increases, madam, with if the systemic vascular resistance is static, that is not changed, the blood pressure will go high, madam. It's decreasing, the blood pressure will go down.
If there is lot of peripheral vascular resistance, what will happen to the blood pressure with the same cardiac output?
Should go up, madam.
Go on. So let's say you have a patient who is bleeding, a post-trauma patient. You see a tachycardia and a low blood pressure.
Yes.
And so you might see well, in a very young patient, you might see a normal heart rate and a normal blood pressure. So, I mean, how does he maintain the blood pressure in a trauma and a bleeding scenario?
In a minor bleeding, madam, by increasing the heart rate and systemic vascular resistance, in the heart rate, the body changes the cardiac output, and also systemic vascular resistance also increases, madam. By those things, and also sympathetic activity increases and causes venous return to increase. So all three factors contribute to increase cardiac output and maintaining the blood pressure, madam. Or
Right.
in grade 3 or 4 stage hemorrhage, madam,
Yes.
there is no enough blood to maintain this cardiac output. So the patient will have low blood pressure.
Okay. Right. Fine. Good. So likewise, so you can kind of develop your own Viva questions. You would have seen past ones also from your seniors. So try and get yourself very familiar with that. Okay. And try and create your own Viva questions and practice. Right. So cardiac output is stroke volume into heart rate, right? And it contributes by cardiac output into systemic vascular resistance. So if the cardiac output is low in a trauma situation who is bleeding, they will increase their SVR and try to compensate for the drop in blood pressure, right? So can you tell me some relationships between systolic blood pressure and diastolic blood pressure and the SVR, systemic vascular resistance? Any relationships that you know?
Madam, systolic blood pressure depends on the cardiac output,
Yes.
and diastolic blood pressure is on peripheral resistance.
Peripheral resistance, yes. Let's say there's a patient who has got dilated peripheral vessels. So is there a number that you can say to say this patient is having dropped peripheral vascular resistance by looking at the systolic blood pressure and diastolic blood pressure?
Mean arterial pressure, madam.
Anything else in the middle?
Pulse pressure, madam.
Yes, very good. Pulse pressure. Why? What is the reason for the pulse pressure to be noted?
Widening of pulse pressure, ma'am.
Yes. Why do you get a widening of pulse pressure?
Because of the vasodilation.
Pulse pressure is the difference between systolic and diastolic pressure, madam.
Yes.
So when there's a vasodilatation, this increases.
It increases. So the systolic and the diastolic blood pressure is broadened up. Right. So is there any other medical conditions in which you will see surgical patients coming to you having broad pulse pressures like that?
Septic shock, madam.
Very good. Septic shock, because you see vasodilatation and there is broad pulse pressure. So that is an indication for you to start on a vasopressor. So the moment you see a very broad pulse pressure and there's obvious wound with ongoing sepsis or cellulitis, so it is an indication for you to start on a vasoconstrictor, right? So that is how you work out. Right. Okay. How about in dengue?
It's more or less, madam, systolic blood pressure.
It is systolic blood pressure, and plus you can get an amount of vasodilatation also. So have you noted in dengue you monitor the pulse pressure? So because you are looking at this widening of the broadening of the pulse pressure, right? And the other thing is there are many instances. How about in liver disease? Again, the vascular tone is kept by the enzymes, and there are a lot of enzymatic reactions. There are a lot of ions that are needed, magnesium, calcium. All these are needed to maintain the vascular tone, isn't it? If you can remember the smooth muscle function, how does it function in a blood vessel, the nitric oxide, the endothelins, all these are needed to maintain the vascular tone. So in liver disease patients, all these are made in the liver. So the moment they are depleted of that, so they have a dropped systemic vascular resistance. So that is why they also have a dilated peripheral vasculature. So if you touch a patient who is in liver failure, they may be having bounding pulse and warm peripheries. Okay. And So they have to compensate for this dropped SVR with a heart that is already maybe compromised by due to cardiomyopathy and all that. So then they have a thing called the hyperdynamic circulation. So if you measure the cardiac output of that sort of a patient, you'll get a higher cardiac output. So let's say in a normal person, the cardiac output is about 6 liters per minute. But in a liver disease patient, you might see a higher cardiac output. Sorry, about 3 to 4 liters per minute in a normal patient. But in a liver disease patient, you will see a higher cardiac output. For the reason is your SVR is dropped. If you remember the previous picture that I showed you, so here this is dilated. So the heart is pumping so much to compensate for this dilated system. So that is what we known as, if you kind of value it, you will see a higher cardiac output. You see there's a higher volume of blood going out. That is because of the dropped systemic vascular resistance. Right, so good. So you all did the first viva. So let's see what happens in cardiogenic shock. What is cardiogenic shock?
Heart unable to pump the blood, madam.
Yes, so the insult is at the heart or the myocardium. So do you all know the types of shock? Hypovolemic shock, cardiogenic shock, distributive shock, right? And then you have the other metabolic stressors like, so distributive shocks are the dengue shock, anaphylaxis and all that. So cardiogenic shock means the myocardium has got insulted. It may be because of a myocardial infarction, right? So the myocardium is dysfunction. So this could be either a systolic dysfunction or a diastolic dysfunction. So as I told you all already, so in diastolic dysfunction, what happens is the LV is not adequately relaxing. So there's no relaxation. It is so tight. So that is why there is left ventricular increased end diastolic pressure. So there's inadequate filling. The heart is unable to relax. So then there is ongoing pulmonary congestion, right? So because of that, it is unable to do good oxygen diffusion. So there is hypoxemia. So because of this hypoxia, there is ongoing ischemia. So the ischemia is worsening. So it becomes a vicious cycle. So for you to, so that is one mechanism. So if you look at the systolic function of the myocardium, again, as you all correctly said, the systolic function will determine the cardiac output. So if the systole is not happening properly, the cardiac output is less and the stroke volume is less. So because of that, there is very poor systemic perfusion. And because of that, the body is trying to have a compensatory vasoconstriction. So hypotension will give rise to coronary underperfusion. Somebody, can you tell me where is the coronary, how does the coronary perfusion happens?
Coronary perfusion mainly occurs during diastole, madam, because during systole, the myocardium is contracting and the coronary vascular resistance is high, madam. During diastole, it's relatively low, so perfusion occurs there, specifically for left ventricle.
Yes, very good. So which is the driving pressure for coronary perfusion? Where is the driving pressure for coronary perfusion?
It's one MAP, madam.
It's
During
the MAP.
diastole.
Yes. So the diastole decides the MAP also, isn't it? If the diastole is low, your MAP is also low. And so the other thing is you have to maintain the aortic root pressures. Where does the coronaries origin? The coronaries origin from the aortic cusps. Very good. So there you have the coronary sinuses. So if you drop the pressure at the coronary sinuses, where the patient is hypotensive, your coronaries are underperfused. On top of that, if you have a LV dysfunction where the left ventricle is unable to relax, so the subendocardial ischemia is possible because the left ventricle is not relaxing, right? So there you have ischemia. So all these are proning the myocardium to be more ischemic. So then there is progressive myocardial dysfunction. Unless you do an intervention like revascularization, you cannot salvage the heart, right? So this is what is happening in the cardiogenic shock, right? And so on top of that, sometimes the myocardial dysfunction can be due to sepsis. What happens in sepsis? Again, you have the systemic inflammatory response. There are a lot of cytotoxins that are being produced. It all obtrudes the myocardium and the contractility is less. So then again, the same vicious cycle happens and the coronaries are underperfused. That is why you see during sepsis, most of the patients are on not only on NORAD for the vasoconstriction, but also on cardiac supporting inotropes, right? So let's see what these inotropes are. So this myocardium is very fascinating. The myocyte has lot of functions. So it has kind of chronotrophic effect. Chronotrophy means it can increase the rate of contraction. So the heart rate is increased by the positive chronotrophic drugs. And if you have positive inotrophy, it will increase the contractility. So that is why the inotropes are used, right? Then you have positive dromotrophy. That is a conduction of impulses or velocities through the myocardium, because it is nicely, it has a nice circuit to conduct the electrical current, and also it has the positive luciotrophy, that is the rate of myocardial relaxation, right? So the myocardium is able to relax. So these are some of the features of myocardium, and there are some more. Any others that you know of? Chronotrophy, inotrophy, dromotrophy, luciotrophy? There's another function. I'll let it for you all to find out as homework. Okay. So, I mean, these can appear in MCQs. That is why I just wanted to mention. So it has 5 properties. So 4 are here. There's another one. Okay. So the rate, conduction velocity, contractility, and the heart rate, relaxation is also very important, right? Right. So let's move on to the functional unit of the myocyte. So if you carefully look at the muscle, you know this is the myocyte, and it has myofibrils, and you have these the joints or the functional unit from here to here. So the contraction or rather the stretch, the optimal stretch will decide on the contractility of the myocyte, right? So you have to learn that in your histology and the physiology. So we'll go to few MCQs just to recap on what we discussed up to now. So can somebody try this? The Frank-Starling relationship, or else you can post in the chat box. Frank-Starling relationship is based on the initial length of the myocardial fibers and the force generated by contraction. Is it true, false, or partially true? Cannot be determined. Yes, to be true. Answer is A. Right. Yes, answer is A, and it is true, right? So it is based on initial strength, right? And let's go to the next second MCQ. The tension in myocardial fibers decreases as sarcomeres are stretched to their optimal length. Yes. Optimal length, yes. One person says B, that is false. Yes. A and B. How about the others? A, the tension in the myocardial fibers decreases as the sarcomeres are stretched to their optimal length. A, B, both answers are coming up, true and false as well. Any other answers? So think about the tension. Does it reduce? Okay, so it is false, right? It doesn't reduce. Okay, so because tension, it doesn't reduce when it is stretched to the optimal length. So optimal length is the one we need to have the optimal cardiac output. So tension, it doesn't decrease, right? So the tension is maximal at the optimal stretch. Right. Let's go to the next question. Right. How about this one? Did we skip any questions before? Yeah, we skipped one, isn't it? Right. How about this one? An increase in ventricular diastolic volume stretches the myocardial fibers more during diastole, increasing the force of contraction. Is that true or false? Only if preload is constant, depends on afterload, only during exercise. Yes, most of you all say it is true. Yes, the answer is true. because increase in endostic volume, it stretches the fibers. And so because of that, the more it stretch is up to the optimal level of stretching, the left ventricle will have the optimal contraction, right? So the answer is true. So the force of contraction does not depend on afterload, and not only during exercise, and only if the preload is constant, that is also false, because the preload will increase. So the next question, during systolic heart failure, the Frank-Starling curve shifts upward, indicating better cardiac performance for a given preload. People say B and C, depends on medications, can be either, none of the above. So some say it is false. Right, so it is false because systolic heart failure means so your cardiac output is low, and the Frank-Starling curve shifts upwards, indicating better cardiac performance is wrong, because you should have a lower curve, because the heart in systolic heart failure your cardiac output is less, right? So that is why. Okay, let's go to another question. Beta blockers cause an upward shift in the Frank-Starling curve in the short term. So what will happen with beta blockers? So we'll be talking about the receptors in the myocardium in a little while. So beta blockers, what does beta blockers do?
It reduces heart rate, madam.
Yes, it reduces the heart rate. Any other beta receptors, beta agonists in the myocardial fiber? What are the types of beta agonists that you know of that are available in the heart? Is it only for the rate? So always remember when they are describing the Frank-Starling curve, so it is like this, right? So upward means it is an improvement, right? This way is an improvement, upward shift. If it says downward, it is a deterioration. So it reduces the contractility too. Yes, it can reduce the contractility because it affects the rate and the contractility, right? And also it has some peripheral vascular effect also. It reduces the beta blockers will have peripheral vasodilatation effect as well, right? So because of that, it is wrong, because beta blockers cause an upward shift. So we are suppressing the contractility, so it cannot go upwards, right? Because what we are doing is we reduce the contractility. So by that, your cardiac output is going to be low, right? As you slows down the heart, you reduces the contractility and you reduces the strain on the heart. Basically, you are kind of settling the heart down if the heart is doing too much of exertion, right? So the answer is false.
Madam, can't we think like this, madam? When the heart rate is going down, the diastolic filling time period is increasing, madam.
Yes,
So the initial stretch will increase, and the Frank-Starling curve shift upward.
So you have a point there. But if you think about in the short term, let's say you have given a short-acting beta blocker, suddenly you will see a drop in the heart rate and the contractility both. So then your stroke volume drops and your heart rate also drops, which will give in short term, you will have a shift of the Frank-Starling curve to the left side. But if you look at long term, as you say, because the heart is slowing down, there is a chance for the left ventricle to stretch more and the cardiac out to be more. Okay. So if it says it depends on the duration of administration, something like that, then you might have to have two answers here. Okay. Is that clear?
Yes, madam. Yeah.
Okay, right. Okay, how about this one? Decreased contractility can result from conditions such as myocardial infarction and dilated cardiomyopathy. How about the answers? It's an easy one. Yes, A. Others agree? A. A's, lot of A's coming up. Yes. It sounds like the myocardium is sick, isn't it? So there's decreased contractility in myocardial infarction or dilated cardiomyopathy, your myocardium is sick. Yes, true. So there is decreased contractility, right? So the contractility is depending on the healthiness of your myocardium, right? Okay, next one. Increased afterload causes a downward shift of the Frank-Starling curve, similar to decreased ionotropy. When you increase the afterload. Always try to relate with the Frank-Starling curve. So your answers, some say A, right? B, anybody telling B? So some say B, it's false. Is it controversial? So actually it decreases, isn't it? Because now theoretically, if you think when the afterload is more, the contractility is difficult. Left ventricle might struggle to push out blood, right? So there's a resistance. So the forward flow is theoretically less. So because of that, you can take it as true. Then catecholamines such as norepinephrine shift the Frank-Starling curve downwards during exercise. Right, most of you are agreeing with B. Right, yes, it is false because during exercise, okay, you get a catecholamine surge, so you expect the Frank-Starling curve to be lift upwards, so moving towards the left side, right? So it is false. Right. How about this one? An increase in ionotropy due to norepinephrine infusion will shift the Frank-Starling curve upwards. Is that correct? Yes. A. Frank-Starling curve shifts upwards. Is that correct or wrong? Or is it only happening in heart failure? Or it depends on the preload? Only with beta blockers. So most of you all say it is true, isn't it? Right. Okay. So the answer is also true. And so it shifts the curve upward. Just wanted to brainstorm a little bit with the Frank-Starling curve. That is why I just put some kind of bit of similar MCQs, but you need to think. So always try to draw the graph. So whenever you get a MCQ on Frank-Starling curve, draw the graph and then work out. Okay. So practice drawing, think about the preload, think about the afterload, think about the contractility. So it's a very simple diagram, just 3 lines, but such a lot of details, you can write books and books on it. Okay, so that is the wonder of graphs. Right, so let's look at the location of receptors. Any questions up to now? All good? Right, so let's look at the receptors and the location. So we already discussed about beta receptors. So if you look at beta 1, so it is located in the heart. So the action, as you all said, it increases the contractility, which is the inotropic effect of the heart as well as the rate. So it has both inotropic and chronotropic effects. Whereas if you look beta 2, again it is in the circulation. So it has some vasodilatation property with beta 2. And also it is located in the lungs. That is why it has bronchodilation property. If you look at alpha 1, it is receptors that are in peripheral blood vessels and also coronary and renal circulation. That is why when you give vasopressin, you might get a renal vasoconstriction. You might get a drop in urine output, right? And that is why sometimes we go for drugs like terlipressin rather than vasopressin. So they causes vasoconstriction, smooth muscle contractions, and increase in the systemic vascular resistance. That is why in sepsis, when you have sepsis and septic shock, when your initial fluid resuscitation and the 1 hour bundle fails, you have to go for potent vasoconstrictions where you fail to maintain the mean arterial pressure, you go for noradrenaline, right? That is to get the alpha effect route. And then you have the dopamine receptors, which are in the D1 and D2s. Those are located in the mesenteric renal as well as in the coronary arteries. So that is why we use, so it is used for vasodilatation. And also, if you look at the inotropes in our practice, so what are the inotropes that you all have seen by now? Adrenaline, or we call it as epinephrine. Then you have noradrenaline, which is again known as norepinephrine. Then you have dopamine and dobutamine, right? And others like isoprenaline, milrinone, right? And sometimes enoximone. So these are the ones that are available for us. Then you have minor ones, if I would say, you would have seen very commonly in the theaters, ephedrine, phenylephrine, right? We use metraminol, right? So these are sort of mild forms of vasoconstrictors and inotropes, right? So each of these have actions which you can relate to these receptors. If you take adrenaline, so it has beta 1, beta 2, alpha 1 effects. Noradrenaline, again, you have alpha 1 effects. So we'll be discussing that in a little while. So these are the strong or rather potent. So if noradrenaline is not working well, we go for vasopressin, right? Which is more specific for vessels. And so ephedrine, phenylephrine, metraminol. So ephedrine has both alpha and beta actions. Phenylephrine is pure alpha, which is a potent vasoconstrictor, and metraminol is again both alpha and beta, right? And isoprenaline is beta 1 and beta 2, right? And milrinone is especially for pulmonary hypertensions, where you get right heart failures. Milrinone is the drug of choice, right? Again, it has beta 1, beta 2 effects, plus it produces forward flow. This is through phosphodiesterase inhibition action, right? Phosphodiesterase inhibitors. If you can remember how they work on the smooth muscles. So this is the way it works, right? Let's go to the individual inotropes and their receptors in a little while. So let's look at the action of beta agonist. Let's say we give a beta agonist. So such as, let's say we have given adrenaline. So there are beta receptors on the cell membranes, which increases the cyclic GMP or the GTPs, and then you activate the cyclic AMP pathways, right? So where it is mediated through the calcium channels, so increases the calcium in the cytosol, and it activates the actin-myosin troponin interactions, which gives rise to a positive inotropic effect. At the same time, they can directly go through the calcium channels and give a positive chronotropic effect. And not only that, it activates the other pathways by augmenting the uptake of calcium from the smooth endoplasmic reticulums, and there will be vasodilatation, right? So likewise, so the mechanisms are there. If you look at the cellular level, so when you give a beta agonist, these are the receptors. So the AMP is converted to cyclic AMP, and so it activates the calcium, and so there's calcium release. So there are calcium sensitizers where there is troponin C on the myosin filaments, and there you will get the contractions. And so the sarcoplasmic reticulum is releasing this calcium to activate the contractility. So this is how each inotrope or the vasopressor act. So you have alpha 1 receptors, alpha 2, beta 1, beta 2, and beta 3 also, and also dopamine 1 to 5 receptors. So vasoconstriction is brought about by adrenaline. You can see they have alpha 1 receptors. So if you look at the adrenaline, what is the main function? It is beta 1, which is the inotropic, dromotropic, and the chronotropic effects. So it increases the rate, contractility, and the the speed of conduction of the electrical current. So not only that, it has alpha effect, so it increases the vasoconstriction effect also, a bit of alpha 2 as well. So that is why adrenaline we use during anaphylaxis. Somebody might ask, why not noradrenaline? Why do you use adrenaline in anaphylaxis? Because there is again a distributive shock, isn't it? During anaphylaxis, you have a vasodilatation, sudden histamine release, and there's a vasodilatation. But the drug of choice is adrenaline because it has all these effects. If you use noradrenaline, you might not get a tachycardia, and you will only get a potent vasoconstriction, right? You can see the other additional effects also because it has a bronchodilation effect when you compare with noradrenaline. So in anaphylaxis, you need a bronchodilation as well because most of the time patients go into bronchospasms during anaphylaxis, right? So that is why we use adrenaline over noradrenaline. And in noradrenaline, you can see it's a potent vasoconstrictor acting through the alpha-1. And not only that, it has beta-1 effects as well as beta-2 into a very low degree. When you look at phenylephrine and metraminol, those are both potent alpha agonists, and also it has mild alpha-2 receptor actions also. So ephedrine is majorly it is beta, plus it has some alpha effects as well. So it constricts the blood vessels as well as increases the heart rate, right? And dopamine, so we go by the doses. So you can see there was a concept called the renal dose of dopamine, but it is no longer said so. Those days they used to say if dopamine is less than 5, it is a renal dose. But it was controversial. The reason was people realized that the renal effect comes because dopamine increases the mean arterial pressure anyway. So that is why there was an improvement in the blood pressure and the urine output ultimately. Right. So there are particular doses like 5 to 10 and less than 2 where they get the dopamine effect. So natriuresis, planchnic vasodilatation. So that was the evidence to say that it was the renal dose. But then you can use 5 to 10 mics per kg per minute where you get the inotropic effects, bronchodilation, vasodilatation. And so when you go more than 10, you get more vasodilatation. And dobutamine, if you look at, so with beta-1, you have more chronotropic, inotropic effects and chronotropic effects, and isoprene is also the same. Right? So dobutamine is more cardiac specific. So if you have a patient who has got a myocardial infarction, we preferably go for dobutamine because through the beta-2 effects, it has a vasodilatation property, which is a beneficial thing for a sick left ventricle where you increase the forward flow and you reduce the strain on the left ventricle. So if you carefully look, you increase the contractility of the heart with dobutamine. At the same time, you reduce the peripheral vascular resistance, thereby you increase the forward flow of the left ventricle, right? And isoprene also is the same. You can see it is very friendly, cardiac friendly. You have the desired effects for a post-MI patient, right? So is that clear? So that is how we decide on our inotropes, right? So adrenaline, ephedrine, dopamine, dobutamine, isoprene, you can call them as inotropes. But what are vasopressors? Noradrenaline, phenylephrine, or metraminol, you can call them as vasopressors plus vasopressin. Okay, so those are the vasopressors. Now let's look at what to monitor during inotropes and vasopressor support. Now you are aiming at a rise in blood pressure, you are aiming at a rise of systolic muscular resistance. So how can we monitor whether we are really treating? So again, we use the basic cardiovascular physiology knowledge to monitor the outcome. So our final outcome is the cardiac output or the cardiac index. So it becomes a cardiac index when you consider the age and weight of that particular patient. Let's say if you want to go for cardiac output readings, it is a generalized reading for a generalized population. Let's say for adult males, the cardiac output is 4 liters per minute. But for particular Mr. M or particular one patient, if you enter their weight and height, you get the cardiac index. So that index value is only unique for that particular patient's weight and height. Okay, that is how we go for specific numbers. What is the drug of choice in cardiogenic shock? Dobutamine or noradrenaline? So in cardiogenic shock, we use both because dobutamine gives you the contractility of the heart, and you promote the forward flow. At the same time, since you want to maintain a diastolic blood pressure and also you want to maintain a mean arterial pressure to get the coronaries perfused, we use noradrenaline as well. So generally, when you see a patient, most of them are with noradrenaline and dobutamine, that is to counteract the effects. But you don't excessively increase the noradrenaline to excessively increase the SVR, or you don't excessively increase dobutamine because it will give out a excessive tachycardia. So tachycardia is not good for a sick myocardium because you are reducing the diastolic time if you increase the heart rate. So the resting time is less than, which will harm the heart. So because of that, usually we strike a balance. So the place to strike the balance is determined by these cardiac output parameters, right? So you go for the optimal numbers and you adjust your inotropes looking at these cardiac output parameters, right? Okay. So both can be used. Dobutamine and noradrenaline can be used in combination. If you have seen in cardiothoracic ICUs and all, most of the time we use noradrenaline and dobutamine combination because we need both actions, right? So cardiac output is one. Stroke volume, we measure the stroke volume and also stroke volume index. So SVR, systemic vascular resistance, as well as systemic vascular resistance index. So always I comes as the index for that particular patient. So then we have so this is extravascular lung water index, where you measure the volume of the water in the lungs, which is an indicator of pulmonary edema. Then we have the pulse pressure variation. Then we have the systolic pressure variation, right? So these are some of those parameters that we use to assess or monitor the inotrope requirements and the vasopressor requirements during surgeries as well as in the ICU, right? So how can we detect the cardiovascular dysfunction? So you have the basic parameters like heart rate, blood pressure, non-invasive blood pressure, ECG, right? So those are the basic parameters that you will have. So if you see a tachycardia, if you see arrhythmia, if you see a blood pressure drop, if you see a broad pulse pressure, look at the ECG, look for any bundle branch blocks, T inversions, so all that are basic cardiac output monitoring. So from that, you can advance to invasive arterial blood pressure monitoring, where you get beat to beat blood pressure. Here, you only press the button at a time, then you get a reading. But here, you get a beat to beat blood pressure on the monitor, right? So adjuncts like saturation fluctuations, capnography are also indicators of cardiac output. Let's say if you don't have adequate cardiac output, the capnography reading is very low because the cardiac output is less. So in this monitor, you can see some of these features. So you can see the ECG. If there's any arrhythmias, you can see. And on our monitors, sometimes you can see here there are ST segment analysis where we detect the ischemia, ongoing ischemia, and there are arrhythmia analysis where we can see the ectopic beats appearing. And then we have the arterial blood pressure monitors. Sorry about that. So you can see the arterial blood pressure waveform. So this is a beat to beat blood pressure that you can see. And this is a pulmonary arterial pressure, PAP, and the CVP, as I mentioned, AC and the V waves, X and the Y descents, you can see. So saturation, again, if there's a fluctuation up and down during inspiration and expiration, that is an indication that the patient is low in volume, low in intravascular volume. And in the capnography, if the height is very low, it indicates that the patient's cardiac output is low, right? So not only by the arterial waveform or by a sophisticated cardiac output monitor, even by looking at the ECGs, looking at the saturation waveform, you can decide that the patient is behind the fluid or not, right? If you want further clarifications, just let me ask me, because I can explain how the saturation plethysmograph changes with fluid status of the patient. So, right. So, if I move forward about invasive blood pressure monitoring. So, when you start your training as registrars, future registrars, you will see arterial blood pressure cannulas being placed in the forearm for especially for major surgeries, because we need the beat-to-beat blood pressure monitoring, right? So it is a cannula placed in the arterial line, special arterial catheters, and it has a pressure bag, and you will see there's a transducer in the middle, always the anesthetist is meddling with those, and then you will see the waveforms on the screen, right? So there are sharp surgeons, sometimes they look at the monitor and just complain and comment about the things. This is the way it appears, right? And so you will see the non-invasive blood pressure every 5 minutes or so appearing. And here you will see the arterial blood pressure appearing as a continuous waveform, and it is correlating with the ECG, right? And also correlating with the pulse waveform. Right. So, I mean, arterial blood pressure, again, like the Frank-Starling curve, if I go on talking, this we can write up to many textbooks, because this simple graph gives such a lot of information. So looking at this graph, so this is the systolic, so it has an upslope, diacritic notch, and a downslope. So this part is the systole up to the diacritic notch, and this is the diastole. So we take a lot of calculations from this. Upper part is the systolic blood pressure, and lower is the diastolic, and this is the mean arterial pressure. Right, so already we have obtained 3 readings, and the area under the curve will decide on the stroke volume. For each beat, the stroke volume is area under the systolic graph, right? So this was used to calculate lot of cardiac output data, and those are being shown as waveforms and also as numbers. So one thing just I wanted to mention, so because diacritic notch and the mean arterial pressure are related, so just think, if you have a septic patient who has got a low diastolic blood pressure, so his graph should be different. So although it goes up like that, because of the low systemic vascular resistance, the diacritic notch comes very close to the low level, and the diastolic blood pressure will be very low. So by looking at the position of the diastolic, the diacritic notch, by looking at the diacritic notch, you can say whether this patient's systemic vascular resistance is high or low. Let's say you have got a septic patient, his diacritic notch will be very low, right? You might see waves like that. So these changes are because of the dilated intravascular system, or the dropped systemic vascular resistance. So, so if you look at the next set of graphs, you can see what I described. So this is the area under the curve. So this is how we get the cardiac output into heart rate. So this is the stroke volume. And just a bit of physiology, I'm just wanted to show you how physiology is being used in calculating the cardiac output. And this is how you see numbers on the screen ultimately. And so this is what you see on a cardiac output monitor. So you will see the cardiac output as 3.4, and this is the blood pressure, heart rate, and this is the stroke volume variation, heart rate variation, and there, when you give a bolus, this is the response we see, the stroke volume variation being very high, it come down. So the normal stroke volume variation should be less than 15 if the patient is adequately fluid resuscitated. If your patient is behind fluid, so the stroke volume variation goes up. It goes more than 15. And when you give a bolus, we can see this on the monitor as a response to the volume. So I just wanted to show you how we use physiology to measure the cardiac output and to monitor the inotrope support that we give and the fluid we give. This you might see during major surgeries in your theaters when you work, and also to appreciate that all these use the Starling's curve principle, right? So sometimes you can see when you give volume, the Starling's, this is the place your patient is, and you can see how your patient moves upward in the Starling's curve, right? So the physical principle is the same in each of these behind. So it is the basics physics and the physiology that you all learn being used in these machines, right? So again, this is the waveform, and if this waveform is going up and down, there's a systolic pressure variation. So this variation is calculated. So if it is swinging too high and below, the systolic pressure variation is too much, which is telling that the patient is behind fluid or he's hypovolemic. So you need to give volume. So then it corrects and comes to a regular rhythm, right? And there's another indicator, so pulse pressure variation, because when you look at a bunch of arterial waveforms, you will see it is swinging up and down during inspiration. So during inspiration, you know, our intrathoracic pressure drops. So when there's a drop in intrathoracic pressure, there's a lot of volume coming into the thoracic cavity, or rather into the right side of the heart. So if the patient is hypovolemic, you will see this swing very much. During inspiration, there's a huge gap for fluid, and during expiration, you can see a drop. So if the patient is filled with fluid, this swing will be less, right? So here you can see a hypovolemic patient where the pulse pressure variation is 32%, and here's a patient whose volume is being given and the pulse pressure variation has come down to 5%. So this is a corrected one. This is a patient where you would need volume. So that is the number that appears as pulse pressure variation on the monitors, which we guide again. The cutoff is 15%, and if it is more than 15%, we need to give fluid, and if it is less than 15%, you can wait, right? So this is how it appears on the screen: systolic pressure variation, percentage of pulse pressure variation, and the systolic pressure variation as a reading taken as manually. Right, so the other cardiac output measuring methods, so there are many other, like esophageal Dopplers, we have transesophageal echoes, where you can see the heart. Here you can get the measurements out of the parameters. So you might all see all these, and also you can assess your heart with an echocardiogram. So here on this video, you might see how the chambers are being shown. So if you look at here, so this is what the cardiologists see, and also the anesthetists. Nowadays, we do echoes during the surgeries, and this is the cross section of the left ventricle. And the one before was the outflow tract of the left ventricle. Here is the outflow tract. This is the mitral valve. You can see it is flapping. This is the left ventricle, and this is the right ventricle and the tricuspid valves, and this is the left ventricle. And this is the, can you see the papillae also? So we can see the visual assessment of the left ventricular filling, and you can see the flow. If you put color Doppler, you can see the flow towards the ventricle. So this is how we visually analyze the heart and the cardiac function. So if there are any hypokinetic segments that we could see. So here you can see very nice contractility, and this is the kissing sign, if you say, where you will see the ventricles coming up, and there's very symmetrical contractility in the left ventricle, right? But in illnesses like myocardial infarctions, you will not see this symmetrical contractility, right? So that's about all. So any questions up to now? There's something on the chat box. What happens to pulse pressure variant if there's a fluid overload? Yes, there won't be any variation. You won't see anything, but it will be flat, or rather there won't be any variability. You will see a very even looking set of waves, and your pulse pressure variation will be definitely less than 15 in number. Okay. Any other questions? Any other questions you want to ask? So Viva wise, stick to the basics, draw the curves, practice the curves. They can ask to describe very simple things, and anaphylaxis in septic shock, what happens, MI, which is a cardiogenic shock, what happens, and what sort of inotropes can you start? So think about those. And yeah. Any other questions? So I think we can wind up then. Right. Thank you very much for your very patience listening. And so I will share the presentations through the department. So I'll make sure that Himali or Inoka will send you the links for the recordings if you all want. And yes, wish you all the very best for the exam, and I hope to see you all in theaters in the next year. Okay.
Thank you.
Thank you, madam.